Yeah, thanks for having me, Roger and Luis. This is not only my work. There's a couple people in the front row here who contributed quite a bit, or hopefully I do it justice. But I started as an open deformity trained surgeon, and I sort of have been transitioning to trying to find less invasive ways to achieve good outcomes. These are my disclosures. So we're increasingly recognizing spinal deformity in patients that come in. They may not be billed as a spinal deformity. They may come in as a foraminal stenosis or have radicular complaints, as this patient did, but also has a mild deformity. And this is not somebody that I think would probably be benefited to have a large open T10 to iliac with osteotomies. But this is somebody whose deformity needs to be taken into account when offering them treatment options. There's a high prevalence of scoliosis in the adult population. This has been well documented, ranging up to 70% in older patients. And we continue to be able to offer better and better options for patients. Older patients are now candidates. We have options for patients with lower bone density with some of the medications and some newer technologies. And we have more options for sagittal plane reconstructions as discussed prior, especially with the anterior column resections. However, morbidity remains high with a significant complication rate to open procedures. And these are sort of retrospective analyses of prospective data. So these are probably underreported, but we're talking 20% major complication rate at least in patients over 65. And then when we're doing big osteotomies, it's 80%, but really ineffectively probably 100% complication rate. So these are significant complications and significant operations to put people through. And like I said, big open operations can be necessary. They can entail significant muscle dissection, blood loss, complications we discussed, long operating times, higher risk of infection, long hospital stays. I know everybody talks about how their patients go home in one day. I'll be honest, mine don't go home, very quickly. And they often need extensive rehab. And then for not all patients can be candidates for operations that may make them feel better. So again, not every patient needs a T10 to iliac, in my opinion. And so the whole point of deformity surgery, I think, it should be you're trying to tailor your approach to what the patient has and offer them the best option for their specific deformity. So I started looking into MIS as I've been here with Roger for a long time. He kind of convinced me about the potential for MIS, less dissection, decreased morbidity, shorter recovery times, decreased length of stay. And now more candidates, I think, are more patients are candidates for MIS or procedures for their deformity, whereas they wouldn't be a candidate for open deformity procedures. There are some concerns, of course, with MIS for spinal deformity. Number one is surgeon comfort with procedures. We sort of had in the past, but probably less so, two camps: MIS surgeons focus more on degenerative, and deformity patient surgeons who did open operations but maybe weren't as well trained in MIS. And I think that's changing. But again, you have to have comfort in both understanding deformity principles as well as MIS techniques. One of the main concerns is achieving arthrodesis in these long constructs. And then also the sagittal plane correction is a major concern. Again, sagittal plane deformity has been described, often requires osteotomies, or sometimes there's some newer advanced techniques to correct patients towards what we consider normal. And when we look at MIS deformity, its early applications, which were only about a decade ago or so, were really much better at coronal correction than sagittal plane correction. So at the time, around 5-6 years ago or so, the group with Mundus, Eastlack, Wani Ribe, and I, among others, looked at how do we discuss with people a rational way to approach applying MIS techniques to deformity patients. And really in 2014, when we published this, MIS deformity was limited to degenerative disease with a moderate amount of coronal deformity and no significant sagittal deformity. So anybody that required a significant sagittal correction ended up in class 3, which was traditional open procedures. But in the meantime, there's been a lot of advances in less invasive techniques. There's been a reinvigoration of the anterior approach, combined AP approach with advances in cage technology, especially in A-lifts, but also in lateral. And there's been advances in navigation, among other things, which make MIS a lot more feasible for many practitioners. And again, improved lateral access, as we discussed already, improved techniques, improved instrumentation. And as already mentioned, ALL releases gain more acceptance for certain patients that need sagittal plane deformity correction. Improved navigation and posterior percutaneous instrumentation. I am very new to percutaneous instrumentation. I never do K-wires. I just do unified procedures, and this is all due to newer and, in my opinion, much simpler instrumentation. Again, some of the tracking that I do in my multi-level navigated operations. So another change that's happened is that we've started to develop a more nuanced approach to the sagittal plane. When I first started, it was very much, there was a one number we wanted to hit for every patient for our sagittal plane correction. But over time, we found that that number changes based on your age and your overall sort of health and bone health. And so now we've basically found that sagittal plane correction does make a difference, but as you get older, that number becomes higher and higher. No longer does everybody over age 70 need to be corrected to less than 5 centimeters of postural sagittal balance. And that thinking is continually being addressed, and more nuanced publications continue to come out. So we looked at that one paper, elderly patients who were not as well aligned. They did as well as those people who were aligned. And so therefore, those patients could be addressed with MIS techniques that maybe would not get them the quote-unquote aligned state that we traditionally would like them to be in. So at that point, we thought it was time to update the algorithm, went through with a bunch of the surgeons and discussed this using the Delphi technique. And we came up with this more newer one. It's just recently been published in the Journal of Neurosurgery. And this time we have 4 classes, ranging from class 1, which is very minimal deformity, class 2, which is sort of the moderate coronal deformity, and then class 3, which is the more advanced MIS techniques to deal with sagittal plane deformities. And then class 4 are traditional open cases. And again, this is a way of thinking about it. We're not saying if you have these parameters, you need to do one of these 4 sort of operations. It's really about where you are comfortable and what the patient needs. But this is a rational way to approach radiographic analysis of patients with deformity. So class 1 is a very mild deformity. I'm just going to breeze through this because I'm a little bit short on time. Class 2 is a little bit more significant coronal deformity. Class 3 is a patient who in the past would be treated open because of their sagittal plane deformity, but because of newer techniques, maybe be able to treat it with a less invasive approach. And then class 4 is your more traditional significant fixed deformity or prior operated deformity who would not be a good candidate for MIS techniques currently. So then we went through and we looked at this algorithm. Was it reliable and reproducible? And the answer was yes. We had a very high kappa when every practitioner applied it appropriately, and we had a large number of cases with perfect agreement. So again, less invasive deformity techniques, as we will go through here, rely upon inner body techniques and having an open inner body space. And so this begs the question, which we just had a nice conversation on, which technique should you use and when? And I think that really depends on what are your goals. Are you talking about indirect decompression, direct decompression, sagittal plane correction? And so to further look at this, our group used 223 MIS surgeries collected over a 5-year period. And we looked at each level, what approach was used, and then what segmental lordosis outcomes were achieved. And so when we looked at this, we found that lateral approaches were preferred for foraminal decompression, for indirect decompression, and ALIF was generally used at L4-5 and L5-S1 with the greatest segmental lordosis change, much more significant than either TLIF or lateral L4-5. And then the most significant segmental lordosis was achieved at L2-3 and L3-4 with the few cases that were done with an anterior column resection. So again, it really depends on your level that you're looking at, your comfort with technique, and what your goals are. And so we're putting together, and this is in submission, sort of a way to look at each level, what options you have for MIS approaches for deformity. And this is just a way, a framework for looking at your options at each level. So again, the case that I presented initially, it was a class 2, and instead of doing a bigger operation, we did a 3-level lateral with MIS percutaneous posterior instrumentation. Some limits, as we talked about, and thank you.